So big picture, endometriosis is a condition in which tissue that resembles the inside of the uterine cavity or the uterine lining is actually located in the wrong place outside the uterus. So these ectopic or abnormal locations can include generally other parts of the pelvis. So oftentimes behind the uterus or on the ovaries, sides of the pelvis, or even the bowels or the urinary tract. But they can also be located in the upper abdomen and sometimes even as far up as the thoracic cavity. Endometriosis most often causes pain, and so that can include pain with, most often presents with pain with menstruation or with periods. Other times that people can experience pain is pain with sex, bowel movements, or urination. Can also contribute to infertility and just general reductions in patients' quality of life. So can be a very severe disease for some people. In general, we consider medical and surgical treatments to be kind of the mainstays. So medical therapies often involve hormonal suppression, and that works in a few different ways. It's generally a progesterone-based kind of hormonal suppression. So it can treat the endometriosis lesions themselves to prevent them from continuing to grow. It can also suppress periods, which are oftentimes one of the major sources of pain for people. So if they're not menstruating, that really can reduce their overall pain. And then medical therapies can also suppress ovulation or stimulation of the ovaries, which means that things like ovarian endometriomas don't grow as quickly. And then when we move to surgery, there's kind of a host of therapies, but surgical treatment options can include conservative therapies. And by that, I mean that we remove the endometriosis, but we actually preserve the reproductive organs for future pregnancy or for other reasons. And the gold standard for surgery is really minimally invasive excision of endometriosis. There's also the option to ablate, or you can think of that as kind of burning the endometriosis lesion, but that's really only an option for superficial forms of the disease. For patients who maybe are done with childbearing or have more extensive disease and have decided that this is the route that they want to go, we can also, in addition to excising the endometriosis, sometimes more definitive surgeries can involve removing the uterus, cervix, tubes, and then sometimes the ovaries. And that's usually based on their goals and, like I said, the extent of disease. I mentioned that we really rely on minimally invasive approaches to surgery that allows us to visualize the lesion. So we really start with a careful examination, generally of the pelvis and the abdomen. We identify any lesions that are characteristic of endometriosis, and those can be kind of superficial, dotted along the lining of the abdominal cavity. Those can be deeper, involving nearby structures, and those can also be cysts on the ovaries or endometriomas. So when we remove them, we really need to be careful to preserve all nearby structures that are not endometriosis. So that can involve the reproductive organs, blood vessels, nerves, urinary structures, bowel. So we make sure to preserve all of that and then carefully and kind of meticulously remove the endometriosis. And that's just really important because the endometriosis can distort the normal anatomy. So we really have to take our time to kind of maximize safety and maximize the amount of the disease that we can remove. So most people do quite well after minimally invasive excision of endometriosis because of the small size of the incisions. Typically by 1 to 2 weeks, many people feel that their pain control and their postoperative symptoms are reduced significantly. However, we usually recommend about reducing activity for about 6 weeks after surgery. So that means heavy lifting is reduced, and that really helps the abdominal incisions to heal. I think the first thing that patients should do is really bring their concerns to the attention of their primary care team or their gynecologist or both. And it can really be helpful to advocate and just say exactly what their concerns are, that they are experiencing pelvic pain, they're concerned they may have endometriosis, and they really want to make sure that they see someone who's well versed in those conditions. I also recommend or remind people that there are other causes of pelvic pain as well as endometriosis. So it's a very complex condition for many people because there can be overlapping sources of pain that can include adenomyosis, so kind of a cousin of the disease that can be located in the uterus. There's myofascial or musculoskeletal sources of pain from the pelvic floor, the abdominal wall, and other sources like irritable bowel syndrome, painful bladder syndrome, or interstitial cystitis. So even if ultimately endometriosis is not diagnosed surgically, there are many treatment options for these other conditions that can cause pelvic pain. And it's important that we kind of treat each condition together and make sure that the patient is that kind of their holistic experience is really understood and addressed.